Sir, good morning. Good morning, sir. Good morning.
Good morning, sir. Good morning. How are you, sir? Fine. So, I would like to share the slides. Shall I share here? Hello?
Very good morning, sir. Yes, sir. You can share, sir, your slides.
From more, I have to share, na? Shall I share here? I have to select more, no? From more.
Hello? Yeah, yes, sir.
But
Share screen option is there, sir.
where?
On the...
Where is
yes.
the option like share screen, na?
Yes, sir. Share screen
Okay.
option is there.
Is it visible?
No, sir. You have to click that screen also on that screen also. Once that screen appears, no, you will have to click on that also. It is not still visible, sir. Are you trying to share it? Hello.
Hello.
No, I think he has left. He will.
Rejoin. Yes, sir. So, is there any echo from my side?
No, not that much.
Okay, sure, sir.
Is my voice clear?
Yes, sir. It's quite clear.
Yeah.
Shall we start, sir?
Must let him join first because he has left again, I guess. Is he there?
Dr. Shrikant, you can start with Dhanvantari Stavan. I think, or had our guest joined?
He had joined, but he is not able to share his screen, I guess. So he has left. Maybe he will rejoin again.
Okay, I just talked to the Kalidas Chavan sir. He is also on the way and he is also going to join.
So should we wait for him to arrive, Dr. Kalidas Chavan sir?
I think we should wait for 5 minutes because he was facing some range problem and he said that after reaching the destination, he will again join it.
Yes, sir. Yes, sir. So by that time, Shrikant sir, can you please call Dr. Gidwani and help him how to share?
Sure,
1 minute, yes, sir.
You personally call him better.
Yes, yes, yes.
Good morning, Dr. Wage, sir.
Good morning, sir.
Good morning. Jai Jai.
Yes, sir, we can see your screen now. That's fine.
Yes, it's visible now.
I'm audible now?
But screen is visible, but your voice is breaking now.
No, it's okay.
Is it okay now?
Yes, loud and clear.
Yeah, fantastic.
Yes, yes.
Okay, shall we proceed, sir?
Yes, Dr. Shrikant, you
Yes.
can start the proceedings.
Okay, thank you, sir. Very good morning, all. And welcome all to this session on World Heart Day, organized by Jupiter Ayurved Medical College and Tarini Ayurved Hospital, Shankarpur, Nagpur. On this occasion of World Heart Day, Jupiter Ayurved Medical College is organizing a webinar series on the investigative procedure to invite all of you to join us for Dhanvantari Stavan. Lord Dhanvantari Stavan. I will play the
Voice is waiting for me or is it working for everyone?
He is talking for everyone, sir.
His voice is breaking. Okay.
Okay.
It's not the range problem is there.
No. So shall I need to proceed or what?
Lord
No, sir. We will let you know. We will let you know. Just please wait for a few minutes.
I will play the
Waiting for me or is it working for everyone?
He is talking for everyone, sir.
His voice is breaking. Okay.
Okay.
It's not the range problem is there.
Copy.
So shall I need to proceed or what?
Lord
No, sir. We will let you know. We will let you know. Just please wait for a few minutes.
I will play the
ये आपने बोला है ना
Waiting for me or is it working for everyone?
He is talking for
शंखं चक्रं
सिरियल मस्त आहे दहा ते अकरा पाठवलं मी पीजी ना
जलौकां दधत् चारुदोर्भिष्टतु
यायला देता नाही
त्यांचं तिकडूनच आहे ते.
तिकडनं बरं झालं चला आपला आवाज तिकडे जातो का सर
हो जातं इथून म्यूट करता येईल हा इथे म्यूट
म्यूट कर
Wage, sir.
Hello.
Yes. I just talked to the Shrikant sir. There was problem with his lappy and he is again replaying the Dhanvantari Stavan.
Okay. Gidwani, sir, please wait for a few minutes.
Yes,
We will first complete the. You can mute yourself by that time.
Okay.
For
Sure.
that time, yes.
Give me a whistle of yours.
ये आपने बोला है
Waiting for me or is it working for everyone?
नमामि धन्वन्तरीरादिदेवं सुरासुरवन्दितपादपद्मं
He is talking for
शङ्खं चक्रं
Serial mesti 10 पाठवलं
दातारमीशं विविधौषधीनां शङ्खं चक्रं च लोकान् दधतमृतघटं च लोकान् दधतु सूक्ष्मस्वच्छाति चारुदोर्भिष्टतु
clear येते नाही
मौलिमं
सतीकुमार
तिकडनं
नेत्रं
बरं झालं सगळं
इथून कुठं करता येईल I think
पीताम्बराढ्यं वन्दे धन्वन्तरिं तं निखिलगदवन प्रौढदावाग्निलीलं प्रौढदावाग्निलीलं प्रौढदावाग्निलीलम्
Now, I would like to request respected Dr. Subhash Wage sir, Principal of the Institute, for welcome speech. Over to you, Dr. Subhash Wage sir.
Thank you, Shrikant sir. It's very good morning to all and one and all. I welcome our today's guest speaker, Dr. Sanjay Gidwani sir, in this event. I welcome all the participants, my colleagues, the program coordinator, Dr. Raviraj Pardesi, Dr. Kalidas Chavan sir, who the registrar of the Maharashtra Institute of Health Sciences, Dr. Shrikant Deshmukh sir, who is the faculty dean of Ayurveda at MUHS Nashik, and the Surya Prakash Jaiswal sir, who has been appointed as the observer for the webinar by Maharashtra Institute of Health Sciences Nashik. And I thank the university officials for approving our webinar and allowing us to use their logo, and that within a very short span of time. I thank them for processing our request within short span of time. Earlier also we conducted a webinar series. It was a very practical oriented webinar series. Still we are that webinar series is being viewed on the Facebook, and we received a lot of feedback from our audiences and the participants. And again, when we are celebrating today World Heart Day, my friend Dr. Ravi Pardesi sir came with an idea why shouldn't we celebrate in a different manner by celebrating as a World Heart Day week. So we thought over it and just gave a shape to the idea of this webinar, consisting of series of 5 lectures of pertaining to cardiac investigative procedures. Why we chose the investigation part is because our partner association, Rog Nidan Vikruti Vignan PG Association, is also conducting this program in collaboration with us, and the diagnostic part is what important to the PGs of Rog Nidan and the PGs of Kaya Chikitsa. And echocardiography being one such modality of diagnosis which can diagnose the wide array of cardiac diseases, right from the ischemic injury to the regurgitant defects, stenotic defects, and shunts, etc. So that we are going to know within few seconds. So I wish once again all the best to the young buddies we have joined, and hopefully this our activity of webinar will generate enough enthusiasm and interest in them to pursue the pursue their interest in investigative procedures. So thanking one and all. Thank you. So over to you. I think Dr. Shrikant sir, just make sure whether Kalidas Chavan sir had joined us.
Yeah, sure, sir. Just a moment.
Because he was locked in the traffic, he said. We can then allow him, if not, joined it. Just make it sure.
No, sir. He has not yet joined.
Okay, Dr. Deshmukh sir is going to join us tomorrow. He has conveyed me. We can start the program. So I request my friend Dr. Raviraj Pardesi sir to please introduce Dr. Sanjay, our distinguished today's guest, Dr. Sanjay Gidwani sir, and proceed further. Thank you.
Thank you, Vagey sir. Good morning, one and all. I feel very honored and privileged to welcome you all on this webinar series, which we are conducting on investigative cardiology. And I feel equally honored to welcome Dr. Sanjay Gidwani, who is interventional cardiologist and is associated with majority of the top hospitals in Nagpur. So he completed his MD in general medicine from BSS Medical College, Burla, Odisha in 2009. And later on, he went on to complete DNB in cardiology from very reputed care hospitals from Hyderabad. And after that, he has been engaged in performing various kinds of cardiological intervention, including coronary angiography, angioplasty, IVP insertion, pacemaker insertion, and he has expertise in device implementation also. Apart from being a member of prestigious institutes like IMA and AMS, he is a member of a CSI Vidarbh chapter also and is associated with the Society of Cardiovascular Angiography and Intervention. I personally know him as a dedicated cardiologist who is dedicated to his profession and to his patients as well. So it is a very glad moment for all of us to have you, sir, on board. Now I request you to address the gathering. The audience.
I will just interrupt Dr. Raviraj sir. MUHS observer Dr. Surya Prakash Jaiswal sir is with us. Please,
yes.
I welcome him and please allow him to say a few words about express his opinion regarding our.
Yes. Sir, Gidwani sir, Dr. Surya Prakash Jaiswal is a head of the medicine department at Ayurveda College, Yavatmal.
Okay.
So we will, yes.
Thank
Jaiswal
you
sir,
very
please.
much.
Jaiswal sir, please.
Dr. Pardesi sir, Dr.
Yes, sir, namaste.
आणि डॉक्टर संजय गिडवानी सर.
नमस्कार.
वर्ल्ड हार्ट डेच्या निमित्ताने महाराष्ट्र आरोग्य विज्ञान विद्यापीठ अंतर्गत ज्युपिटर आयुर्वेद महाविद्यालय नागपूर यांच्या वतीने बेसिक्स ऑफ इकोकार्डिओग्राफी अँड इट्स युटिलिटी डायग्नोसिस ऑफ कार्डिक डिसऑर्डर या विषयाला धरून सुरू केली आहे. त्यासाठी मी पहिले ज्युपिटर आयुर्वेद कॉलेज आणि प्राचार्य आणि तिथलं सगळं मंडळ यांचा मी विशेष अभिनंदन करतो की आमच्या पोस्ट ग्रॅज्युएट विद्यार्थ्यांसाठी दिशादर्शक हा एक टॉपिक आहे. कारण वर्ल्ड हार्ट डेच्या निमित्ताने दरवर्षी आयुर्वेद महाविद्यालयामध्ये विविध प्रकारचे आयुर्वेदिक दृष्टिकोनातून एक वेगवेगळे वेबिनार प्रस्तुत केले जातात. परंतु हा वेबिनार पर्टिक्युलरली डायग्नोसिस ऑफ कार्डिक डिसऑर्डर याला धरून म्हणून मी या ऑब्झर्वर या नात्याने आपल्या संयोजन समितीचे एक विशेष आभार मानतो आणि आजचे जे लेक्चर प्रस्तुत करतायत डॉक्टर संजय गिडवानी सर आणि त्यांचा विषय आहे बेसिक्स ऑफ ग्राफी अँड इट्स युटिलिटी इन डायग्नोसिस ऑफ कार्डिक डिसऑर्डर. त्यांना शुभेच्छा देतो की आजचं हे लेक्चर आमच्या पदव्युत्तर विद्यार्थ्यांना आमच्या सगळ्या स्टाफना विशेष पद्धतीने पुढे आपल्याला या सेक्टरमध्ये काम करण्यासाठी दिशादर्शक ठरो. एवढं बोलून मी आपल्या वाणीला जय आयुर्वेद.
Thank you very much, sir.
Thank you, Jaiswal sir. Sir, you can start now, please.
Thank you, Raviraj sir. Actually, good morning, one and all. Actually, respected Dean of the MUHS, Professor and Head and Principal, and Dr. Subhash Yogi sir, Professor and Head Dr. S.K. Jaiswal, and Dr. Raviraj sir, and Dr. Hadole sir. Thank you for inviting me for lecture on World Heart Day. And being a today Heart Day, I am very glad actually to just present a topic which will be not only for the purpose of learning, but it will help you to give more enthusiasm toward cardiology as well. So being a basic topic, I am just covering echocardiography. I would have been learned if I would have given more topics also. But right now we are starting with one of the lectures. Today I have been appointed to give it That is basics of echocardiography and its utility in diagnosis of cardiac disorders. So let us start it. So what is an echo? Echo is something you experience all the time. If you shout into a well, the echo comes back a moment later. The echo occurs because some of the sound waves in your shout reflect off the surface, either in the water, at the bottom of the well, or on the wall of far aside, and travel back to ears. A similar principle applies in cardiac ultrasound as well. So, what is the history of the echo? And this is a Doppler, you can say, or sonography, you can say. In 1842, Christian Johann Doppler, 1803 to 1853, noted that the pitch of sound waves varied if the source of sound wave was moving. The ability to create ultrasonic waves come in 1880 with the discovery of piezoelectricity by Curie and Curie, the same that were involved in radiography actually. Dr. Helmut Hertz of Sweden in 1953 obtained a commercial ultrasound sonoscope which was being used for the non-destructive testing. He then collaborated with Inger Elder, who was participating as a cardiologist in Sweden. Two of them began to use this commercial ultrasonoscope to examine the heart. This collaboration is commonly accepted as the beginning of clinical echocardiography as we know it today. So this was the history. Let us go with the ultrasound image. What is an echocardiography? Is a type of ultrasound test that uses high pitch sound waves to produce an image of heart. So the sound waves are sent through a device called as transducer and are reflected of the various structures of the heart. These echoes are converted into a picture of the heart that can be seen on a video monitor, and there is no special preparation test required for it. It is a simple high pitch sound waves to produce an image of the heart. That's it. Simple principle. So this is an echocardiographic machine. You can see this is an echo machine having a probe, a screen, a button, and software programs. So this is a basic echocardiographic machine looks like. So what are the 5 basic component of ultrasound scanner that a machine has? Usually it is a pulse generator. It applies the high amplitude voltage to energize the crystals. One is pulse generator. Second is transducer, that doctor uses it, converts electric energy to mechanical energy and vice versa. Receiver detects and amplifies the weak signals. Fourth is display, that is display ultrasound signals in variety of modes. Fifth is memory. Simple: pulse generator, transducer, receiver, display, and memory. These are the components of any ultrasound scanner. So this is the way that how the reflection and emission and transmission usually occurs. That ultrasound gel is applied to the transducer to allow the transmission. Many of the people have seen and undergone ultrasound. People might have, doctors might, every doctors might have seen how the ultrasound is been done. Just simple reflection. That is, ultrasound gel is applied to the transducer to allow the transmission of sound waves from the transducer to the skin. And then transducer performs the echo-mechanical energy into an electrical signal which process and displays in the form of wave. So this is the way that emission, then reflection, then return. The conversion of sound waves to electrical energy is called as piezoelectric effect. What we are able to see? Are you able? Everybody is able to see now?
Yes.
Yes.
So this is basics that I wanted to proceed before you proceed for any echocardiography or ultrasonography. So this is nothing but called as piezoelectric effect. We are dealing with piezoelectric effect. So this is a grayscale image. Somebody sound humming. Can please unmute? Someone sound is humming, please. Someone sound is humming. Hello.
We should request everybody to keep themselves muted.
Please keep yourself muted. This is a simple grayscale image. Whenever we see any echocardiography, Just a simple image. Now, what it stands for? Black stands for fluid or blood. White stands for calcification in the cardiac walls and pericardium. Gray scales for myocardium. So this is a black, that is could be a blood. This is a gray color. So this is a myocardium, endocardium, whatever you say, or a heart. This is white stands for here pericardium. So white stands for pericardium. So I am proceeding for simple echocardiographic techniques. So I am an observer or I am a doer as a cardiology. So this is the way the echocardiogram is performed. It depends on the individual doctor or a cardiologist to go with the left hand or the right hand technique. Both hands are used. If the right hand technique is used, the machine is usually on his left side, and he proceeds with the button or with the left hand and uses his hand for echocardiography as a right hand as a dominant hand. And if the machine is kept on left side, he uses his left hand for echocardiography and right hand for using the operating the machine. I use with the both hands. I am practiced with both the hands. So your patient lies in recumbent position with the left side position. Sonographer moves the transmitter on the chest. This is the site of the heart. Here we are seeing the apex view. And these are the electrodes attached with the chest. Electrodes are attached to see the ECG changes, and according to that, whether the heart having any change in the rhythm pattern or some pattern that we are observing in the ECG, whether the echocardiography is showing the same pattern also. This is very important. That's why we attach the ECG leads in the patient whenever we are doing echocardiography. So there are very number of windows. Windows means a position where we can see the picture properly. And there are many positions of the probes, that is probe, that we use to place in particular area and to check the particular structure of the heart, so that we will see it in the best way and look out the best way of the disease of the heart in that position. The structure which are seen in particular position, according to that, there are views that are being named. That is parasternal view. First is parasternal. Second is here is apical. Third is subcostal. Fourth is suprasternal. Here short axis view is not been shown. I will show you in some other view. So basically that there are different types of sonography routes or echocardiography routes that we use for the heart. Of this, what we commonly use is transthoracic means to the chest. There is another way that is called as transesophageal. We go through the help like endoscope like transesophageal route. Third is intravascular, that is used for coronary intervention. It can be intracardiac or intracoronary. For intracardiac, we use for AICD, another procedure for kidney ablation. Intracoronary, we use for stent placement. Last is epicardial. So commonly what we use is parasternal, this transthoracic window. Whatever the echocardiography is said, commonly we know it as we are doing like transthoracic route, unless it is mentioned with other routes. So transthoracic echo that we use is the views which we see is left parasternal, apical, subcostal, right parasternal, suprasternal, posterior thoracic. Posterior thoracic is very rarely used window. So these are the different modes that we see in any echocardiography. One is simple M mode, second is two-dimensional mode, third is now advanced stage is three-dimensional mode. So two-dimensional mode M mode is usually it is a time wave. So whatever the time you will put the sonic wave, it will show the pattern. Two-dimensional, whatever the conventional echocardiography we see as a picture, it is two-dimensional. Three-dimensional is when you computerize analyze with a 3D probe, you will get the geometrical and structural analysis in different pattern with a different pitching. If you properly allocate that particular segment, and you can delineate and crop the segment according to your wish by making it as a 3D structure. So 3D is the advanced, and now the 4D has also come. So 3D is also being used very commonly in majority of the metro cities. So let us go into the details of echocardiography, how a cardiologist performs it. So this is the parasternal long axis view. You can see the transducer is placed in the second and fourth intercostal space and on the left sternal edge. Marker dots are directed towards the right shoulder, and the most of the study begin with this view only. We commonly view this. I have put this, suppose the probe like this, and I will see the structure of the heart like this. So this is the heart. This is we can say anatomical structural it is been shown, and this is the echocardiographic structure that we are able to see. So here what we will see in this view is parasternal long axis view is the right ventricle in size and function. Here in left ventricle we can see. Here we'll see ascending aorta, then aortic walls, mitral walls, and pericardium. So this is the aortic wall, this is aorta, this is mitral wall, this is left ventricle, this is RVOT, you can say right ventricle outflow tract, or you can say right ventricle, you can able to see. This is septum, interventricular septum, left ventricle wall, and you'll see the left atrium as well. So this is a parasternal short axis view. What we do is just we clockwise rotate in the same position to the probe towards the left shoulder, and we see the various sections according to which we can see the different type of structure in the echocardiography. So you can say it A, B, C, D. I have put it at A, B, C, D. A is the structure where we can see the aortic ball level. So I have to just rotate the probe little up, and I will just see the structure like left atrium, right atrium, aortic wall, right ventricle outflow tract, pulmonary wall, and pulmonary artery. So here is the view where we can see and cut down, or you can see the probe by tilting just up, and we can see the different structures like both walls, like commonly aortic wall and pulmonary wall. You can say RVOT as well. This is commonly is used to see whether there is a pulmonic stenosis, pulmonic regurgitation, or valvular regurgitation, aortic wall calcification, or here we can say pulmonary artery usually communicates with the left side aorta. You can say aorta, you can see the PDA, you can say descending aorta, you can see. So pulmonary artery usually communicates here with the patent ductus arteries of the descending aorta, and we can see that there is a PDA also. This view is also used to see for the ASD as well. So this but the way this ASD will be looking here, it will be should be a very large ASD only. So ASD is atrial septal defect. Second is use this B, section B, we can see at the level of mitral ball. The transducer is positioned horizontally, and we can see anterior mitral leaflet, posterior mitral leaflet. This is left ventricle cavity, and this is right ventricle. Third level is C, C at the level of papillary muscle. We can see the below mitral wall on the left side. There are papillary muscles we can see, and these are very prominent. Anterior papillary muscle and posterior papillary muscle. You can see at the section at that level. That is called as metaventricular level. And you can see the RV. RV is usually thin, and LV is usually thick. And fourth is apical level. We can see the smaller apex that you will have less number of trabulation in LV, more number of trabulation in RV at the apex, but it is usually thin walled. So you can see the apical four chamber view. We have to position the probe at the apex of the ventricle and tilt up towards the left shoulder. And we can see the number of views, we can see the number of structures here. That is, we can see here one is as a pericardium, you can see as a pericardium here. Like then is left ventricle, this is left ventricle, this is left ventricle, this is left ventricle. Septum, RV, this is septum, this is right ventricle, this is septum, this is right ventricle, this is RA, right atrium, LA, right atrium, then left atrium. This is interventricular, the interatrial septum, IAS, interatrial septum, then mitral annulus and tricuspid annulus. This is a mitral annulus, this is a mitral annulus, this is tricuspid annulus, this is tricuspid annulus. So we can see overall structure of the heart in apical four chamber view. So this is a apical 5-chamber view. We have to just modify a little tilt, and we can see the aortic wall as well. So we can see the mitral wall, aortic wall, tricuspid wall, left atrium, right atrium, interatrial septum, interventricular septum, left ventricle free wall, right ventricle, and right ventricle free wall. So this is one of the best view. We can see everything in this. Only we have to tilt it. So these are the another views that are called as apical 2-chamber view, where we have to tilt the rotate the probe in the apical view only to the left, and we can see the apical 2-chamber view where we can see left ventricle and left atrium, and we can see the papillary muscles as well. This is a suprasternal view. We have to put the probe on the above the sternum, and we can see the aortic arch and its branches. So we can see the brachiocephalic artery first, then second is this one left common carotid, third is here left subclavian from here, and then is the descending aorta. So the thing is that this is a suprasternal view we can see. Then is subcostal view from below the xiphisternum. We can put the probe in the horizontal direction with the pointers towards the left, and we can see the structure. This view is commonly used actually for assessment of atrial septal defect. Second, for congenital heart disease, we have to know which type of solitus it is, solitus, but because it should be situs solitus, it means single, and solitus means same single heart, whether the heart is left side, right side, dextrocardia, levocardia, position of the IVC, whether it is going with that or not going with that, a great vessels, we can see and start with this view usually in congenital heart disease. When subcostal view, we see the same structure like left atrium, left ventricle, RA and RV. This is also used for when the patient is having severe COPD. COPD means chronic obstructive pulmonary disease or asthmatic patients. We may not see a good view of the left parasternal or apical view. We may see a good view in subcostal view. So when the position of heart is displaced because of the lung diseases, we can use this as a view for assessment of the heart. Moreover, it is the first view where we use in congenital heart diseases. So imaging domains. What are the imaging domains of echocardiography? That is which I told you earlier. I explained that single line interrogation, that is M mode. Multiple line interrogation is 2-dimensional. Multiple dimensional imaging is usually 3-dimensional imaging, that is called reconstructed imaging, which I already explained. Now there are Doppler domains, that is there are pulse Doppler domain, that is single interrogation volume, multiple interrogation volume. It may be M mode or a color imaging. Then is speckle tracking. Let us forget this analysis domain variant. These are the most advanced technique that we use. So this is a simple way that I put the probe in the left parasternal view, and I am able to see the heart. This is the sternum. This is the chest wall. This is a right ventricle free wall. This is right ventricle. This is interventricular septum, aorta, left atrium, entry mitral leaflet, posterior mitral leaflet. These are chordae. This left ventricle. This is a papillary muscles, and we can see the posterior left ventricular wall. So this is a simple way that we can see whenever we put the probe in left parasternal view. So this you can see. This is the way we are able to see the echo picture. I have not made knowingly any running echo because it will take lot of time. So whenever you take, I have taken the freeze echo pictures. This has the left parasternal view where we are able to see. This is the typical picture we are able to see in echocardiography while doing the echocardiography. This is the right ventricle, left ventricle, left atrium, aorta. This is the closed aortic wall. This is the open aortic wall. I wanted to show both the pictures. So whenever there is a mitral wall opening, the aortic wall has to close. Whenever there is an aortic wall opening, mitral wall has to be closed. So this is the way that we are able to see the structures whenever we are doing a conventional 2D echocardiography. This is the long axis view. This is the first long axis view. This short axis view where we are able to see the LV cavity and semicircle circumference is that RV cavity. Then is 4-chamber view. This we are able to see left ventricle, left atrium, and right atrium. And this is 2-chamber view, meaning there we are able to see only left ventricle and left atrium only. So everything is connected to the ECG. We are able to see the ECG electrodes are connected to every echocardiography so that we are able to see the rhythm disorder if we are able to see during the time of doing the echocardiography. So this is the short axis at the level of aortic wall. We can see the aortic wall, pulmonary wall, this interatrial septum, this is the right atrium to right ventricle, this is tricuspid wall, which I showed modified views. So let us go with the why it is important to know the all these views. After knowing, you must know the coronary distribution and supply of every chamber or at least left ventricle so that we are able to delineate which area of the heart has been affected because of ischemic heart disease. That is commonly we see. We can see that in the ECG that there is patient is present with chest pain and the patient has developed ECG changes like entry wall MI or inferior wall MI or lateral wall MI. So which territorial zone we are seeing during the time of echocardiography and which structural abnormality or regional wall motion abnormality at what level we detect. This is the coronary distribution that decides. So here it is labeled as LRC. L stands for left entry descending artery, R stands for right coronary, and C stands for circumflex. So this is the suppose the left parasternal long axis view. You can see that is L means this interventricular septum is supplied by left entry descending artery. RC means R plus C. This supply posteriorly supplied here by the RCA and circumflex. So you can see the short axis view. It is supplied by one segment, second segment, both this segment anteriorly complete down. It will be supplied by LAD. Segment 3 will be supplied by both LAD and circumflex. Segment 4 you can see it's supplied by circumflex only. 5 and 6 RCA and LCX both in parasternal till down. So this is if you can go 1, 2, 3, 4 or clockwise is also okay. You can go from here or you can go from here, whatever the level you want. If you see the 4-chamber view, this basal septum is supplied by right coronary artery and this is the supplied by left coronary till the apex. From apex to apicolateral, this is apex and this is apicolateral wall. So we can see here the septum is basal septum, mid septum and apical septum. So this is a basal septum, mid septum and apical septum. So similarly the basal septum means interventricular septum. So this is basal anterior septum, basal inferior septum, and anterior wall, lateral wall, and posterior wall. So similarly, basal septum, this inferior, this is anterior, and this is here. This is the 4 segments view, is the 6 segments view. So this will become the basal septum anterior, basal septum inferior. This is the anterior wall, this is the anterolateral wall, this is the lateral wall, this is the infrolateral wall, this is the inferior wall. This inferior segment and inferior wall. Both will go together. You can see inferior septum as well. So the thing is that if you see another view in 4-chamber view, can be divided into basal, mid, and apical. So here basal, mid, and apical. This is the apicolateral. This will be the apicolateral, and this is the mid lateral, basal lateral. This will be the mid lateral, basal lateral. So lateral segments are supplied by circumflex. Anterior segments, entry wall, entry septum is supplied by the usually LAD. And if you see the 2-chamber view, this is a 2-chamber view. This is a 2-chamber view. You can see the basal, mid, and apical inferior, and basal anterior, mid, and apical interior. So if you see the 2-chamber view, this 2-chamber view is the inferior wall. We can see of the RCA is supplied by usually supplied by the RCA, and if they see the anterior septum and entry wall, then this is supplied by the left entry descending artery. So overall summary that entry wall up to the entry septum up to the apex is supplied by LAD, lateral wall is supplied by LCX, and inferior wall is supplied by RCA in general. So these are the view we can see, and whenever the patient develops an acute MI, depending upon the distribution of territory, we label is regional wall motion abnormality. Regional means standing for that region, wall means that segment, wall motion means there is no motion, abnormality detected. So in that particular segment, it may be anterior, it may be lateral, it may be posterior. Depending upon the coronary artery involved, then we label it. So in short, The modalities are echo of usually a two-dimensional and motion mode that I already discussed. Then is second is Doppler wave means continuous wave, pulse wave, or a color flow imaging. So this is a pulse wave where we see the patient having wave are usually used for detection of the early and late mitral annular velocities. So these pulse wave Doppler are used. These are usually used to see whether the particular segment pulse wave means same level at single point we see. Single point means I want to see this point only. So what I would make I would arrange the probe and transducer and a pointer I will catch to this area and I will leave the pulse. Pulse means nothing but a short wave that I want to see the particular segment. So the pulse wave means suppose I want to see the mitral wall. So particular area only this wave will be transmitted and that will be reflected from that point only. If I want to see the atrium, then I have to push the pointer to this area. If I want to see the LV apex, then I have to put the pointer to this area. So commonly pulse wave are used at the valvular levels to see the level of stenosis, to see the level of regurgitation, to see any other abnormalities. So pulse wave are nothing but a point generated source of reflection transmission waves that we want to see that level of structure. Continuous wave is nothing but I have to see any wave, what is the maximum frequency in that particular duration, in that particular segment. So from here to here, whatever the volume of blood is regurgitating or is coming as a, can say in some segment, that I have to assess the velocity of the blood. So in particular areas, suppose patient is in severe MR, I want to see the particular velocity of the blood, how much it is fast, maximum limit. So to assess the maximum limit, we put the multiple pulse wave and we see which is the maximum pulse is generated, velocity is generated. Where the maximum velocity is generated, the transmission is taken with the help of continuous wave to assess the maximum velocity of the particular segment to know the severity of the disease. So pulse wave is nothing but a point wave. Continuous is the maximum in velocity that can be addressed from the point source where we are able to see the disease structure. So this is one of the type of contrast echocardiography is one of the type of echocardiography that is usually used to know the very small ASD or patent foramen oval or hepatopulmonary shunts or portopulmonary shunt syndromes. This is the one of the method where we put the patient an IV cannula and we use this interlock syringe and we fill this interlock syringe with a small saline around 2 or 3 ml with a very point 2 or 0.1 ml say air and we both interlocking using three-way we rapidly push the saline into each other into both the say, interlock syringe and to generate the bubbles. These are saline bubble. Saline bubble means saline has generated the air bubble after mixing it. You have to forcefully push and push in both the syringes through the interlock wave and we have to create the bubbles, saline bubbles. And saline bubbles in 1 ml is infused very rapidly into the venous circulation through IV cannula and immediately we have to check the fourth chamber view of the heart. So the bubbles you will be able to see the contrast bubble echo in right and left ventricle because venous system is connected to the right and left, right atrium and right ventricle only. So immediately the bubble contrast will be visible in the right atrium and right ventricle. But if the saline bubble contrast in very few seconds within 3 cycles is appear in the left side, meaning thereby there is a shunt available. Even if there is a delayed contrast visible, so the shunt may not be at the level of the interatrial septum. It may be available at the level of portopulmonary shunt or hepatopulmonary shunt that is occurring through the shunt or pulmonary V fistula that is occurring through the lungs. So if you are able to see immediately saline bubble contrast from right atrium to the left atrium, the bubbles will be reflected into the left atrium. Then there is a shunt available at the level of heart. If after a few cycles we are able to see the shunt of saline bubble contrast from right atrium to the left atrium, meaning there was shunt is available at the level of some other areas, either maybe hepatopulmonary, portopulmonary, or AV fistula at the level of lungs or at the level of liver and lungs. And that is getting shunted through small capillaries to the left atrium. So what are the indications of echocardiography? This is the chart which I have taken. This is directly from the Brownwell textbook of cardiology, so that there should not be any individual presentation bias. So this is the classical chart that are being used from the international guidelines. So there should not be any confusion anywhere from any presentation. So indications of echocardy in the patients of heart murmur. So till this time we have learned what is the echocardiography, what are the position used, what are the parameters we see, what are the views we see, what is the coronary distribution we see, how we see the regional wall motion abnormality, in which view see which what structure we are able to see. Till this time is echocardiography is over. Now what is the purpose of doing echocardiography? So what are the indications of echocardiography? So indications of echocardiography in any evaluation of heart murmur. Once you auscultate a patient in OPD or IPD somewhere admitted, you have seen a murmur, then it becomes an indication. There is no other way out. So a murmur in a patient with a cardiorespiratory symptoms is a class 1 indication. A murmur in asymptomatic patient if the clinical feature are least indicated of moderate possible probability that a murmur is reflective of structural heart disease is also an indication. Even if you see asymptomatic murmur, if you see symptomatic murmur, it becomes a class 1 indication for knowing the echocardiography structure of the heart, what is going in the heart. Class 2 is asymptomatic murmur in a patient whom there is a low probability of the disease. Class 3 is asymptomatic murmur that has been identified by the experienced observer. So that becomes, if you are any experienced observer seeing in adult patient and some murmur is visible very faint, you may not do it. If this is commonly at the level of functional wall, that is called as pulmonary wall is usually functional wall. Rest of the areas are usually as a for use for diagnostic tool. So any murmur, you can use it for evaluation of heart disease. Second, the structural and functional abnormalities, the criteria which are used is suspected cardiac etiology due to suspect cardiac etiology caused like dyspnea, shortness of breath, lightheadedness, syncope, transient ischemic attack, or cerebrovascular accidents. You can use the echocardiography. So dyspnea may be of cardiac origin, or you can say the pulmonary origin. You must do the echocardiography. Lightheadedness, we do not know whether a patient has developed rhythm disorder or supraventricular tachycardia that has led to mitral valve prolapse, that has led to this patient having syncope or TIA, or patient having atrial septal defect or small PFO, which has led to stroke into the patient that has led to CVA. So we have to see the structure of the heart. Prior testing,
10-15 मिनिटांनी बोलतो.
I am not, please. Somebody is talking. Prior testing is concerned of heart disease whenever we are doing an adult congenital heart disease to know the ASD, VSD, and PDA. Then is routinely to know 1 year after the correction of the surgical correction. Patient with arrhythmias like SVT, VT, or you can say non-sustained ventricular tachycardia also. Patient with isolated PVC also to know the other evidences of heart disease. Then the patient having evaluation of LV function that commonly we use as in acute myocardial infarction, patient recovering from acute myocardial infarction, patient having can say a dead myocardium, we can use it to know the thickness of the wall. Then patient having pulmonary hypertension, we can see the right ventricle function and pulmonary artery pressure. Then patient having any other indication which is used for pacemaker implantation, knowing the genetic infiltrative or disorders or genetic disorders like hypertrophic cardiomyopathy, used for CRT implantation and correction, used for heart failure, guideline therapy, directed heart failure, ejection fraction knowing and treating it accordingly. Any cause of hypotension, hemodynamic instability, patient in first degree heart involvement like cardiomyopathy like HCM, we can see and structurally and check their child at the age of 12 years and we can do the echocardiography for them. So echocardiography is also used for valvular assessment of the heart, that is assessment of the valvular based on the function, that is whether it is a mitral valve involvement in the form of mitral stenosis, where we require balloon valvoplasty or operative repair. Depending upon, we use the echocardiography to see the structure of the mitral valve. Then we use other technique like transesophageal echo for, and post correction we use this echo transesophageal echo as well to level the know the how the balloon valvulotomy is or repair had went underwent. Post intervention studies we use. Then we use transverse echo for knowing the other structures of the heart. Then we use
Shrikant sir, are you there?
Yes, sir. Probably he will rejoin, sir. He has
please see
left there. Yes.
I think sir had lost the connection. Please see.
Yes. 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 I request all the audiences to wait. Maybe he has lost the connection. I'm calling him and requesting him to rejoin again.
Has joined us. I welcome you.
Dr. Shrikant, sir.
Am I able to? Are you able to?
Yes. Yes,
Hello,
sir.
am I visible?
Yes,
Now?
yes, you are visible and audible.
Hello.
Yes, yes.
Yes, sir. Go on. Please go on, sir. Please share your screen.
Hello.
Yes, sir. Please go on.
Gidwani, sir, you can share your screen now once again. Hello.
Shrikant, sir. Shrikant, sir, can you hear me?
Yeah, yes, sir.
Gidwani, sir, is not getting access to the Zoom again. Please, you can personally contact him and tell him how to do it.
आकाश ने बोला कि यूएसजी अब्डोमेन चाहिए था कराना था तो लिख के चाहिए प्रिस्क्रिप्शन की वो टेस्ट नहीं करते थे कौन सा यूएसजी अब्डोमेन करने का हाँ तो मैंने जब फोन किया क्लिनिक में
Hello.
Yes, sir. We can. Yes, it's fine now.
Okay. Actually, something I don't know what has happened in between. So I'm sharing the screen again, sir. Huh? Just one
Yes,
second.
yes, yes.
Hardly. Are you able to see now the screen?
Yes, 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 yes.
Sorry for the interruption, but I'm really very apologetic for the things that happen. We'll finish off the next 10 minutes. Everything. Am I audible
Yes,
now?
sir. Yes, yes, yes. Please go ahead.
So, as I told, we use this echocardiography for mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, similarly tricuspid stenosis, tricuspid regurgitation, pulmonary stenosis, pulmonary regurgitation. assessment of the septums, atrial septum, interventricular septum, or you can see the congenital heart disease. So here we use the echocardiograph of timing valvular intervention like in balloon mitral valvotomy or valvoplasty, or you can say operative valvular repair or replacement. Transesophageal echo is used for valvotomy as well as repair disease for guiding as a technique for surgery, which type of surgery is to be performed, whether the preservation of the valvular apparatus is possible or not, then we can use with the transesophageal echo. There's post-intervention, we see the ventricular rebonding, whether it is opening or how does the wall function. Then assessment of prosthetic wall dysfunction, whether the thrombosis is occurring or stenosis is occurring in that patient of prosthetic wall replacement. And using that, we can use the transesophageal echo. We can use the transesophageal echo also to know whether the prosthetic wall is thrombosed or stenosed, which we are not able to see, or there is an infective vegetation small, which we are not able to see on transthoracic echo. So T is one of the tools that can be used for smaller vegetation or prosthetic wall stenosis, or you can say a pannus formation on the prosthetic walls, that transesophageal echo is used. Even transesophageal echo is used to assess the ASD defect, size of the VSD defect, and you can say the patient requiring mitral valve repair or patient requiring aortic valve surgeries, or a patient requiring ascending or descending aortic valve surgeries. At the time the transesophageal echo is used. Then where the echocardiography is again used for the screening purpose of echocardiography. This is called a screening, meaning thereby the patient may not be having disease, but if it is disease also, we can see the patient with a certain other disorder where we are supposed to see the patient related to multi-system disorder. We can see use the screening echo to the cardiovascular status of the heart. So patient having family history of genetic transmission, which I told you already. There may be congenital diseases, there may be acquired disease. Commonly family diseases are congenital diseases. We see one of them is commonly is hypertrophic cardiomyopathy, other is ARVD, arrhythmogenic right ventricular disease. There are many other diseases, Fabry's disease and Mole's disease. There are many diseases. And potential for cardiac transplantation, then we have see patient with the Marfan syndrome. Because of connective tissue disorder, there is the involvement of the heart as well. Patient of chemotherapy undergoing cardiotoxic drugs are used as a chemotherapy, then we can use the echocardiography as a tool for deterioration of the heart or LV function. Patient having first degree relative of unexplained dilated cardiomyopathy whose etiology is not known, there we can use as a screening tool. Patient having systemic disease affecting the heart like systemic sclerosis, you can say retroviral diseases, or you can see the other diseases that might be in multi-system involvement like connective tissue disorder like rheumatoid arthritis and SLE, then systemic disease affecting the heart that we can use at the time of echo. In general population, commonly when the people goes for athletic training, there the echo is used. Patient echocardiography is also used the patient those who are doing a sports activity and other history of heart disease in family history. So this is was till the knowing the 2D echocardiography and trans-esophageal echocardiography. What is the way that we use? What are the views we see? What are the structures we see? What are the anatomical distribution of the coronary artery? What are the segments we analyze whenever we see regional valvulation abnormality? What are the indication of echocardiography as general, as a cardiac point of view, non-cardiac point of view, as a systemic heart disease related view? So there are multiple reason that we have to do 2D echo in a particular patient. So I am discussing now one of the most advanced technique that is available in echocardiography, that is a speckle tracking, that we use a strain and strain imaging technique. That is now this is one of the latest technique that is being used for echocardiography. This speckle tracking is nothing but the incremental value of two-dimensional speckle tracking echography in patient with the functional assessment of the characteristics of subclinical left ventricular dysfunction. Whenever we are seeing left ventricular dysfunction and it is subclinical, you are not able to see clinically, echocardiography is normal. At that time, this technique will help us to know whether the patient having subclinical left ventricular deterioration is there. Then we use this speckle tracking. It has a strain and strain effect. So the strain refers to the change in the length of the segment of the myocardium related to its original length, and the strain rate is refers to the net change in the strain per unit. This is just a theoretical issue. So we have to know that speckle tracking has three aspects: longitudinal, circumferential, and third is radial. So we see the different type of strain pattern, that is longitudinal strain, this circumferential strain, third is radial strain. So these are the different type of strain that are being used in any assessment of the structure related to commonly left ventricle. It may be used for nowadays for right ventricle as well, but it is now most commonly used technique is available for left ventricle. So commonly we use this longitudinal strains. Circumferential and radial strains are also available in the most advanced echo machine. Right now not available in basic echo machines. So this is the circumferential rotation we see of the heart. This is see the longitudinal contraction of the heart. This is the radial strain of the heart. The heart usually contracts like counterclockwise motion, up or down. So it goes in a circumferential, together it clocks and rotates inside. So to push the blood from LV to aorta with the rotational force. So this is an endocardium that is maximally that uses the longitudinal strain. So whenever we are using the strain pattern, we commonly see the endocardium because endocardium is the most commonly affected of the heart. Once endocardium is affected, like its smallest MI, because this is the endocardium is the most farthest of the blood supply area, because the coronary artery distribution usually starts from epicardium. The blood vessels which are originated from the aorta, left artery, left coronary or right coronary, they usually originate on the epicardium. From epicardium, they run over the epicardium surface. They enter into small segmental space like myocardium. Then it reaches to endocardium of the heart inside the heart. So endocardium is the most distal supply of the coronaries. So location of endocardium is the farthest from the epicardial coronaries, and it is the only area where the sensitivity of ischemia is more vulnerable. That is why the longitudinal strain is highly sensitive indicator for LV dysfunction. You may not see the myocardium having loss of segmental structural abnormality sometime, and contraction may be good, but endocardium might be affecting. So subclinical dysfunction of LV can be affected. So this is a way that we can see that there was an old location somewhere in the heart of endocardium, then this is a new location that is changed. So this is the way we see the speckle tracking in any patient. We use the segmental analysis of the heart in every segments, and we divide it into make it that a structural segmental analysis with the wave pattern. We see whether it is going the same direction or going in another direction, on which the scoring is divided, and from the scoring basis we decide whether the patient is going to get LV dysfunction in subclinical way or not, or you can see another abnormality as well. So this is the bullseye picture we form after the segmental analysis, and in that any score less than -15 is bad, -15 and above should be the good score. The good score is also considered for the patient is having better heart. So application of strain that are being used in valvular heart disease, coronary artery disease, hypertension, heart failure with reservoir ejection fraction, perimyocarditis, cancer chemotherapy, and miscellaneous condition. And commonly we use this technique like this. We use the various views. One is 4-chamber view, where we see and put the point 1, 2, 3, and we check the analysis, and analysis is done with the approved. Once it is properly getting graph, the LV will contract and we will get the contractile segment like this. Subsegment analysis is done. You have to approve this, and after approving we will get a graph. Whether the graph is going the same direction or not a good direction, we will get the values. If the values are good, here you can see the values are good. From -14 it is going down to -28, meaning thereby subsegmental analysis is good. If it would have been above, only above -14, meaning thereby the subclinical LV dysfunction is occurring. You can see here the patient having subclinical dysfunction, where the this is a good contractile segment. Here there is not a good contractile segment. We can see the here the segmental score is low, so you can see there is subclinical dysfunction in them. Here the global longitudinal score is -22. Here the global longitudinal score is -12. So you can see subsegmental analysis is bad. Might be a patient might be having LV dysfunction in this case. So this is the way of longitudinal strain we see. Similarly, we see in hypertension and diabetes patient, the magnitude of the hypertension and athlete heart. So this in heart failure with reservoir ejection fraction we see. So there is incremental value of this in every diseases. I'm not going to detail in perimyocarditis, other things. So you can see in uromyocarditis, we can see the patient may not be having good systolic contraction, and you can see pericardium and myocardium that there will be a steno because of the stiffness of the heart. There will be global longitudinal strain might be affected, so the score may remain less in these patients. So in routine evaluation of cardiotoxic drug and conventional, we have to see whether the patient is having subclinical LV dysfunction deterioration. We commonly use this technique nowadays on patient having cancer chemotherapy, patient having Fabry disease, systolic strain initially only are affected in basal posterolateral segment. So there are certain diseases where the only particular segments are involved. So we have to see, like in Fabry disease, only posterolateral segments that they may be thin and affected. Systemic sclerosis, the first strain is going to affect is patients. Longitudinal strain is going to affect. So GLS score will be low in these patients. So this may be a low GLS score graph. We can see the above -13. We are able to see the graph here commonly here. So this is a low GLS score. This may be a patient of DCMP, dilated cardiomyopathy. All over the strains are low in every segments, and bullseye is showing low picture. So this is the case, for example, a patient who was presented to me with a chest pain, having ST elevated MI. I did a speckle tracking, and speckle tracking has showed this segment having almost a zero score, like one score. This was having an acute ST elevated MI. So this is a patient of acute MI that was having GLS score of very less in the septum area. This is another area, the patient having normal segments, hardly any septal defect. These are not considered because the graph is going the same direction. Third is that this is absolutely normal without having any involvement. And this the patient is having involvement of inferior MI. Patient has presented with the chest pain with the ST elevation in 2-3 AVF. The GLS score was less in inferior segments. So this was having inferior wall MI. The other areas were preserved. There was already on angiography, it was showing RC and LCX disease as well. And LED was normal. So this is the way that strain imaging help us. So what is the take home message for us for this today's lecture? So today 2D echocardiography and color Doppler is an important diagnostic tool for investigation of cardiac causes of in day-to-day practice. Advanced echo tests like transesophageal echo, intravascular ultrasound, intracardiac echocardiography, 3D echocardiography provide important information for accurate therapeutic intervention. 2D dimensional speckle tracking, a novel strain imaging modality, is a sensitive indicator of myocardial contractility and subclinical LV dysfunction. So this is the, you can see the Elder and Fingengum demonstrating the M-mode echo in 1968 in cardiac ultrasound, Indianapolis. So where from the started the echocardiography techniques and echography modes. So at the time, this was the only M mode available, and this was a very big machine at that time. Nowadays, handy pocket echocardiography machines are available. With these pioneers, we are able to now discuss the lecture on it. I thank to them today on the World Heart Day because they have given me opportunity for talking on the lecture of echocardiography. Thank you very much.
Yes, thank you, sir. Thank you. It was concise yet comprehensive, as you covered right from the topics, right from the history of echocardiography to the advanced speckle tracking. So, if time permits, can we have few questions, Wage sir?
Yes, yes, please, please.
Yes. So, Dr. Umesh Lunawat want to ask what a general practitioner or a primary care physician should focus on reading to do echocardiography reports. So whether it should be EF or whether it should be RWMA, what are the key points one should see in an echocardiography report?
Yes, yes, absolutely. First is always a chamber, whether the chambers are normal or abnormal, whether it is dilated or normal size chamber, which is written. If it is written dilated, meaning thereby something is abnormal. Second, whether the patient is having normal LV function or deteriorated LV function, either there is a mild LV dysfunction, moderate LV dysfunction, severe LV dysfunction, so means thereby ejection fraction. So whether the ejection fraction is normal, whether it is in the range of 55 to 65 and above, it is considered as normal. If the ejection fraction is less than 55%, it is absolutely considered as abnormal.
And yes, Dr. Kiran Mantri wants to know to what extent echo can diagnose coronary artery stenosis. Is it possible to see the extent of coronary artery stenosis on echocardiography by any means? Hello. Again, he has lost the connection, I guess. Yes. So, Dr. Kiran, as far as I know, the coronary angiography is a gold standard investigation to see actual blockages or stenosis in the coronary arteries. Echo can give a glimpse of regional wall motion abnormality, which is probably because of the ischemia in the affected artery, which is supplying to that particular muscle or wall of the heart. Hadure sir, can we try once? Can we try reaching him once again?
Yes, sure, sir.
Yes. Dr. Sonali is asking whether there is any contraindication to echo and what should be the case. As such, as far as I know, there is
Actually,
no contraindication. Yes, sir. Okay, it's fine, sir. So there is one question. What is the alternative if there is some contraindication for performing echo?
Hello. Sorry. Please tell me,
If
sir. I'm not able.
if there is a contraindication for performing echo, is there any other option available? Are there any?
Absolute contraindication, first of all?
Yes.
No absolute contraindication for doing echocardiogram. Echocardiogram is like a sonography. Nowadays, the machines are mobile. Even in the ongoing OT, we can do the echocardiography. So there is no absolute contraindication for echocardiogram. Till now, date existing for transthoracic echo. If the patient is having left-sided wound on the chest with the open wound, we can do the subcostal window. If the patient is having accidentally left-sided wound and right-sided wound and a subcostal window, then the only parameter remains your ECG to give the fitness. That's it. So there is no absolute contraindication for echo. Nowadays, there is no absolute. Initially, was also not there.
Yes. So there was one more question in between which I answered partly, but I feel that you should answer to it. To what extent echo can diagnose coronary artery diseases? Or
it depends whether the patient is having acute MI or not. If the patient is having acute MI, echo will be 100% diagnostic. There is no doubt. If the patient is having acute ST elevated MI, commonly elevated MI, common word is used. The patient is having ongoing ST elevated MI. Echo is 100% sensitive and specific for it. Knowing the patient is having non-STMI, it cannot stand for diagnostic solving your purpose. Why? Because non-STMI is usually involves the subendocardium, and subendocardium usually do not produces the regional wall motion abnormality unless there is an involvement of myocardium or say myopericardium. Unless it is involved, will not get any regional wall motion abnormality because myocardium is a muscle mass and muscle mass is usually involved in creating contractility.
yes.
And I think question was apart from regional wall motion abnormalities, whether one can detect coronary artery blockages by echo. The question was like that.
Now, if you want to ask me the particular strain, now the purpose of presenting this speckle tracking was the only reason to know whether there is a subclinical left ventricular dysfunction or subclinical involvement of the coronary artery, which is not usually diagnosed on 2D echocardiogram. The sensitivity and specificity of the speckle tracking and echocardiography in detecting subclinical disease of the coronary arteries, the it's not well known, but the strain imaging which we are using nowadays, speckle tracking, it will give a corroborative, collective, can say inclination towards the diagnosis whether the patient is having coronary artery disease or not. But nobody or no investigation or which is non-invasive will give a clear cut saying that the patient is not having coronary artery disease is still not existing. Nowadays, apart from echocardiography, a CT angio which is being used, it also uses injectable dye. So by
Mhm.
doing echocardiography, if you want to know a patient is having asymptomatic coronary artery disease, we cannot evaluate.
Hmm. Right. And
Coronary artery disease we cannot evaluate, but the strain imaging will give an idea that this patient might be having a coronary artery disease and patient has to go and ho another investigation modality.
yes, and in case where there is a physician who is practicing in periphery and wants to thrombolize MI based on ECG, so is it okay even if he doesn't have access to echocardiography to go for thrombolysis?
Ideally, if the patient reaches within 1 hour of acute MI, that is called
Hmm.
as golden hour,
Hmm.
and the physician who is practicing in periphery is 100% sure that is the acute.
Hmm.
Sir,
Hmm. Sir, sir, there is a background voice.
hello.
Yes, sir. Yes, sir. Yes. Please continue.
If the particular physician who is practicing periphery, they are 100% sure of the clinical diagnosis, meeting with the ECG changes in the same direction, and the chest pain is or duration is of 1 hour without having previous history of MI. If the patient is reaching within 1 hour, straightforward thrombolyze without waiting for the echocardiography is not a wrong answer. You can go ahead with thrombolysis. But if you are going after 1 hour, you should do an echocardiography because the complication starts after 1 hour only. Within one
Hmm.
hour, if you are doing, that is a golden period, because at that point of time, you have to save the patient first. Second important time, echocardiography may not be available everywhere. Initially also it was not available, so you used to do thrombolysis there also. So it is justifiable if the patient is reaching within 1 hour to you, and if you are doing the history previously and the patient has not suffered MI and there is no recurrence of MI. Please remember should not be a recurrence of MI in the same territory also. It should be the new onset MI within 1 hour without prior history. And if you are seeing ECG changes within 1 hour, thrombolize the patient. If you do not do the echocardiography is also allowable because that is a life saving. If you are thrombolizing, you are saving the life of him at least by 30%. That will be my
Yes.
have a chance of dying by 30%. But
Yes.
after 2 to 6 hours, if you are going, you must take the help of echocardiography because 2 to 6 hours you are not going to change more in the patient. But yes, thrombolysis period is 6 hours. You get 2 to 3 hours, then you must wait and you get a echocardiography done because the complications start happening once you are crossing the period of 4, 5, 6 hours, and the complications starts happening by thrombolysis. So if you are doing thrombolysis after 6 to 12 hours, there is a chance the patient may develop free wall rupture, ventricular septal defect, or you can say even cardiac arrest because of cardiac tamponade. So without doing echocardiography, after 1 hour, should not do thrombolysis. Within 1 hour, yes, it is justifiable.
Okay, sir. Right. So we will take one last question from Dr. Vedanti. Difference between simple and stress echocardiography.
Simple difference in simple and stress echocardiography.
Yes.
Simple echocardiography is just we do whatever the 2D echocardiography we do.
Mm-hmm.
Stress echocardiography are different types of stress echocardiography that we use, whether we are using pharmacological stress or whether you are using physical stress. Pharmacological stress that we use is dopamine stress echo. Physical stress that we use is usually stress testing along with the assessment of echo with some radioactive dye with technique another. So the different types of imaging that are already existing. So simple echocardiography is usually used to know the LV function and other assessment of the wall, and stress echocardiography used to know the patient is subclinical disease and precipitate with through dobutamine. But what happens? Once you challenge the patient with the dobutamine high dose, with not having EC changes, you are unlikely to get any change in regional wall motion abnormality on the stress. But if there is a ST changes in the ECG and the patient is having history of chest pain, patient is not asymptomatic. I'm saying your patient is symptomatic, but ECG changes, but echo is showing normal. At the time, once you are doing dobutamine stress echocardiography, try to understand the answer. It's very important. Asymptomatic patient with not having ECG changes is very, very unlikely to get any change on stress echocardiography that we do use as a pharmacological method with the dobutamine stress echo with a variable dose of dobutamine. But the patient is having any history of chest pain background with subtle ECG changes with no regional wall motion abnormality on 2D choreography. If you challenge this patient with dobutamine on variable doses depending upon requirement of body weight 5, 10, 15, 20, 40 microgram that we use in stress protocol, and at that time if showing something regional wall motion abnormality, then it becomes a part of symptomatic coronary artery disease. So stress echocardiography is nothing but when we challenge it with a physical stress or we challenge with the pharmacological stress, that is called as stress echocardiography. And simple conventional 2D choreography that we use is simple 2D choreography which I mentioned right now here. I have did not mention anything right now on today's lecture on stress echocardiography because I thought the lecture would be more lengthier. That's why.
Yes. Thank you very much, sir. Vagesh sir, anything else? Vagesh sir.
I think we have crossed the time limit, and we should sum up the things now.
Yeah, unfortunately, there was a two times disconnection from my side.
No, it's so it is quite common when we rely on this net or connectivity. So I thank Dr. Sanjay Gidwani sir for making himself available to deliver a talk on such a most required topic, 2D echocardiography. And at the same time, I thank Dr. Vagesh sir and the management of Jupiter Ayurved College, MUHS observer Dr. Surya Prakash Jaiswal sir for observing this event. So if there are no further proceedings, should I conclude this session, Vagesh sir, with your permission?
Yes, sir. Yes, sir.
Okay. So thank you all. Good day.
Very much, sir. Thank you.
Thank you, Dr. Sanjay sir. Thank you.
Thank you. Thanks a lot, sir. Thanks a lot.
Okay.
Thank you everyone for joining this session. I request all of you to please join tomorrow at 10 a.m. Thank you very much.
Okay.
Okay.